Good morning, everybody. My name is Joseph Murphy. I'm a cardiologist at Mayo Clinic. It's my pleasure this morning to be giving you a talk on strategies for the cardiology board examination in 2014. I have been giving this talk for many years, and this talk is a little bit different. In other words, it doesn't focus specifically on content for the boards, but talks about the format of the boards and strategies that may be helpful to you during the examination. A lot of the strategies that I'll talk about are general, that you can use in other multiple choice examinations, but in the past many of these strategies have been found to be very helpful both by our own fellows and by the attendees of the course. So let me welcome you very much to this course. It's a great pleasure for me to present. I'm happy for any feedback that you may wish to send me, and included in my slides will be my email address. Please feel free to email me with any comments, either positive or negative. Let me first tell you that I don't have any conflicts of interest to disclose. I won't be talking about any off-label drugs or device use. I have no formal links with the ABIM, and I won't be discussing the content of actual ABIM questions that have been used in the past. So this talk is really a multiple choice strategy talk focused specifically on the cardiology boards, which you will be sitting in the near future. So this is our cardiology textbook, which is now available electronically on Kindle. This is my email address, and again, please send me comments, and I appreciate these. So let me start this talk by giving you a quotation for Sir William Osler, who, as you know, was a Canadian, but is generally regarded as the father of US clinical medicine. I have always been opposed to the base and most pernicious system of educating doctors with a view to examinations. Obviously, the ABIM did not judiciously read the quotations of Sir William Osler. He also did, however, make the point, which I think all of us would admit, I do not know of any stimulus so healthy for students as knowledge that they will receive an examination at the end of the course. So I think it's fair to say that Osler was not in favour of examinations, but he felt that they may have a certain utilitarian value, and I guess we all would kind of agree with these sentiments. But it's interesting that he wrote these comments almost 100 years ago, and as we move in the direction of certifying and recertifying an MOC, clearly I think Sir William Osler would have rather different views than the current ABIM. So I'm going to talk about the format of the cardiology board examination. I'm going to talk about the development of board questions, how you're scored, particularly about some pitfalls, tips and traps that I want you to think about. I'm going to talk about examination strategy. I will talk about specific cardiology board examination type questions, although not the specific questions that have been used in past years. And I'll talk to you a little bit about the day of the examination and the things that you should observe. While they may be minor, it's important to get these things correct. So first of all, why does the ABIM use the multiple choice format in the first place? And as I think about this, it's really a strange way to assess competence in what is, after all, a clinical specialty, is to give these puzzler type questions. And the rationale is that these questions are transparent and they're fair, they're relatively easy to write and to mark, and they allow statistical comparisons both between candidates and between years. They're easily ported to the current format, which is a computer-based format. They're not probably a great test of real-world medicine. They're a test primarily of theoretical knowledge, pattern recognition, reasoning and deductive skills. And I would say to you very sincerely, to those who do very well in this examination, that remember that the world of clinical medicine is very different from the world of multiple choices. And equally, for those who may be not so fortunate to do well, that it doesn't mean that you cannot be a wonderful, great and compassionate doctor if your scores are not in the highest tercile. So the first thing I would like to say to everybody is that everybody who has become a physician is more than capable of passing the cardiovascular boards. So the boards are a combination of knowledge and strategy, which equals success. The cardiology boards are predominantly a statistical examination with data derived from a large number of interactions between the question and the candidate. The question obviously being devised by people who are expert in the area. So the aim of the candidate, that's you, is to pick the correct answer if possible. But if you don't know the correct answer, it's important to guess, with one caveat, is that you should not guess on the electrocardiogram and the imaging section of the board. All other questions should be guessed if you don't know the answer. Remember that excluding a wrong answer and guessing strategically is worth real marks. Now, I'm going to show you this because it's interesting. So the pass mark for multiple choice examinations is generally approximately 70% plus or minus 5%. And there are several different ways of getting to the magic number of 70%. One is to know 70% of the correct answers, and then any guessing after that is purely additional marks. However, if you're not quite so fortunate, there are other ways to pass the exam. One is to know 50% of the answers correctly, and then guess 50% of the answers, provided you have excluded 2 of the 4 wrong answers. In other words, you're guessing 50-50, and that actually gets you to 75%. There are other variations on this. One is to know 50%, guess half the questions, and then guess 20% of the questions 1 and 4, and again that gets you to 70%. If you know 40%, you can just about scrape through, assuming that you're guessing 50-50 for all the remainder. The point here is you need to know at least 40 to 50% of the questions cold, and then by strategically guessing the remainder, you can pass the exam. If you don't know the basic 40 to 50% correct, it is very difficult to pass this exam. But if you're in the gray area, where you know kind of about 50%, strategic guessing with elimination of incorrect answers will actually get you across the finish line. So the key to all multiple choice exams, and it's the key to the lie detector test, not that one is quite the same as the other, but it's to get into the mind of the examiner or get into the mind of the question writer. So when you look at a question, I want you to see the person behind the question and get to understand why the question was written, what competence is the question assessing. See the patient who has the condition as described. Remember, most of the questions that are in the ABIM examinations are based on real patients that have been on a clinical service, and the question writer is using genuine, real material that come from real patients. Now, this can be modified by the board, both to obscure the identity of the patient and also to make it into a testable format. But a very useful strategy for an examinee is to try and see the real patient in the emergency room, see the real patient in the cardiac catheterization laboratory or in the CCU, and try and get a sense of what is the decision point of the question, what is the key issue that's being tested. And sometimes with relatively long questions, it can take a while to say, gosh, what exactly are they getting at? Why was the question written? And specifically, has there been a trial that will guide me to the answer? Has there been a specific society guideline which would answer how we should manage this complex patient? So the questions come from real-world scenarios that may be modified to meet the purposes of the boards. They can be tests of factual cardiology knowledge, but in most cases, it's usually a test of clinical judgment, which assumes a knowledge of factual cardiology, but requires a higher order understanding and a test of knowledge in the basis of recent clinical trials or data or expert opinion. The test is also a pattern recognition test. There's a test on the EKG section, which is basically pattern recognition, and similarly that for the cardiovascular imaging section. Remember that this section you do not guess. You will be asked to review an EKG and remark on the significant findings, and similarly with the echocardiograms, MRIs, or other cardiac imaging studies. For these, you do not guess because there is negative marks in this part of the examination. Remember that the cardiology boards is not specifically a test of basic cardiology knowledge as I would apply it to bench knowledge. There may be some basic science involved, but generally it's of a specific application to clinical medicine, such as platelet receptors, where you will use medications that interfere with platelet receptors, such as knowledge of how the renin-angiotensin system works, whereby to treat a patient with heart failure, it's important to understand the physiology. So the physiology that will be asked in this exam is generally limited to 5 to 10% of the questions and is directly applicable to the care of the patient. This test is primarily a test of knowledge integration with a complex cardiology case, knowledge of both the subject matter and of the relevant clinical trials in the area. So, as somebody who's written a lot of multiple choices, and I think most of the other people will tell you the same, the weakest point of any multiple choice is the distractor. The distractor is the weakest point in all multiple choices. What is the distractor? The distractor is the wrong answer that must be close enough to the real answer to fool many candidates, but is also truthful and not mischievous. In other words, you cannot put in a distractor which is unfair or is untruthful, but equally the distractors cannot be so easy that they're obvious. Distractors are very hard to write, and in many cases the distractors are added at the committee stage. In other words, once the question is written by the individual clinician, it is brought to a committee who will review the questions, and it's at that stage that often the distractors are added, where somebody would say, gosh, I think one of your possible answers is either too easy or too difficult or unfair, and at that stage they often get modified. Try to understand the logic of the distractor, as if you understand the logic of the distractor, you will often understand the logic of the question. And watch for the additional conditional clause. In other words, sometimes when a possible answer as a distractor is added, the committee will add another clause to modify it slightly, and that's often a giveaway as to the distractor. When you look at a question, always assess what is the order of the question. So a first order question is, as I give an example here, a patient presents with infective endocarditis 10 days after removal of an infected wisdom tooth. What is the likely organism? Very direct, asking you what the knowledge is. A second order question is, a patient presents with infective endocarditis 10 days after removal of an infected wisdom tooth. What is the optimal antibiotic? Now the logic here is you need to understand what the organism is before you can say, well, which antibiotic will you use? And the way to approach these questions is always answer the first order question that is implied or in your head before you go to the second part. In other words, approaching this question, you would always want to say to yourself, what is the likely organism? And then the second order question, what antibiotic will I use? But make a conscious decision to answer it in a logical sequence. There are obviously higher order questions, third or fourth order questions, but the basic principle is there. Always start by answering the implied lower order answers first. When you look at a question, always watch for the details that stick out. In other words, the one where you said, gosh, why did they put that in there? Every question detail is potentially important, especially things that stick out like the patient's occupation, their race, ethnicity, the consultation location. Is the patient symptomatic or asymptomatic? This is very important when you're thinking about sending somebody for surgery or the urgency of treatment. So there's a very different rationale if you see a patient who is completely asymptomatic, who comes for a routine evaluation for insurance purposes, and you pick up an abnormality on the electrocardiogram, on clinical examination, or on the echocardiogram, rather than somebody who you see who's in the CCU, who's in extremis. So always take into consideration how symptomatic the patients are. If you are given specific measurements, they're usually very important. So if they give you the LDL level, you're being given the LDL level for a specific reason. Equally with the left ventricular diastolic dimensions or the ejection fraction. If the board gives you numbers, there's a reason they're giving you numbers. Now, sometimes they give you lots and lots of numbers, so you have to decide what is the key decision-making number in this situation. Remember that cardiology board questions are generally very well worked. The key to the answer is always in the question. There's no way to answer this type of question, because the format that the board uses, where the questions are written, they're reviewed by multiple committees, they're reviewed by PhD psychologists, they are tested on specific test audiences, and they are often recirculated through multiple examinations. These get all the kinks out of the questions. So when you see a question, it's generally pretty well worked. It can be subtle, it can be nuanced, but the answer is there if you watch for the details. Now, you can use the IBM against itself, speaking metaphorically. So remember, the ABIM must be politically sensitive. So if they tell you the race or the ethnicity of a patient, it must be the key to the answer. If they tell you the HIV status of a patient, this will only be stated if the question requires that the HIV status of the patient be disclosed to you. Occupation is frequently important. I recently saw a patient who had angina on the weekends, but not on weekdays. Turns out that the patient had significant nitrate exposure and works in an explosives factory. So he was obviously having chronic exposure to nitrates during the week, and on the weekends, when he would not get a nitrate exposure, he would get coronary spasm. So remember that occupation, if given, is very important. Geographic location is important. So for example, the board tell you that the patient is from Minnesota. They are thinking about Lyme disease and ticks, or they're thinking about hypothermia. If I see a patient from Minnesota, it's just another patient that I see every day from Minnesota. For the board purposes, if they tell you the patient is from Minnesota or Wisconsin, you're thinking hypothermia during winter, or you're thinking Lyme disease. So often these questions are a little bit different when the board tell you than when you see the patient in your real clinical practice. So for example, if they tell you the ethnicity, remember that specific ethnicities are associated with specific cardiology issues. So for example, if you're Irish, you think about hemochromatosis. Japanese, apical variant hypertrophic cardiomyopathy. Black, you think of repolarization changes on the EKG, or hypertension, or the response to hypertension using diuretics. A South American patient, you'll think of Chagas cardiomyopathy. A patient from Haiti, especially female, you'll think about peripartum cardiomyopathy. Portuguese patient, you'll think of amyloid. Thai patient, you'll think about sudden cardiac death syndrome. So there are certain codes that the board uses. If they tell you the patient is on cardiac medication, that's digoxin until proven otherwise. In other words, if they're giving you the digoxin toxicity question, and there's almost always the digoxin toxicity question, they're not going to spell it out for you to say the patient was on digoxin, the patient had nausea and vomiting, the patient had a low potassium. In other words, there is a certain nuanced approach. If they tell you the patient is a scuba diver and has recently returned from vacation, you're thinking of patent foramen ovale with paradoxical embolus. If the patient is pregnant, think about peripartum cardiomyopathy or spontaneous coronary dissection. If the patient is a recent immigrant, think about tuberculosis, especially about tuberculosis-associated constrictive pericarditis. If the board tells you the patient has recently had a long plane flight, they're telling you that this may be a pulmonary embolus. Weight loss medication, pulmonary hypertension, or valve disease associated with anorexic medications. The patient is deaf, classically associated with the long QT syndrome. Syncope while swimming, again another long QT syndrome typical scenario. Emotional distress in an elderly lady, think apical balloon syndrome or Takotsubo syndrome. Again, all these are very classical scenarios, but often the tip-off is these relatively minor details that sometimes we tend to gloss over. So think about occupations, think about shipyard workers and mesothelioma. And then for the EKG, think about specific things. In other words, with the EKGs, they will give you a short one-liner. So if they tell you the patient is post-thyroid surgery, they're telling you to watch out for hypocalcemia. If the patient is vomiting or diarrhea, again, you're looking for electrolyte abnormality, hypokalemia. The patient has myeloma, again, you're looking for a high calcium. If the patient is on dialysis, that's code for a metabolic type EKG, either with a high or a low potassium, usually a high potassium. So I want you to put yourselves into the mind of the person writing the question, and it may be kind of a scary place to go. But what is the ideal multiple choice question? Well, the first thing is it must have a high discriminant value. In other words, the whole point of the multiple choice is to test a candidate and to decide between candidates. So a multiple choice question is at its most powerful when it has a 50% discriminant value. In other words, 50% of the candidates get it right, 50% get it wrong. Now, what this means is that many of the questions in the exam will challenge you. If the board is setting these questions for a 50% discriminant value, it means that people will get lots of questions wrong, even candidates that are good. So if you are taxed by these questions, that's pretty much okay. The board has probably appropriately set the questions. If the question is too easy, in other words, 80% of people or more are getting the question right, then the question has very poor discriminant value and is not of any particular use to the board. And the interesting point here is that the board can delete questions after the examination. In other words, you have gone through the exam and you have worked hard and you have spent 10 hours in a dimly lit room on a computer screen, but the board can eliminate questions after the examination if they have low discriminant value. Now the plus side is if most people are getting the question wrong, so less than 20% of people pick out the correct answer, or it's pretty obvious that people are guessing the answer. In other words, the dispersion of the answers is pretty well equal between the different A, B, C, or D, then the board can also exclude that question. Because again, if most people get the question wrong, the question has very low discriminant value and it is not of much use to the board. So bear in mind, if you get strange questions and everybody comes out and say, gosh, I don't know what they were talking about, it's highly likely that question will be excluded from marking. Equally, if everybody said, gosh, you know, question number 5 was incredibly easy, everybody got it right, tough luck, that one isn't going to be excluded either. But remember that you will be challenged by many of these questions. Remember the 50% discriminant value that the board is aiming for. So where do these questions come from? Well, they come from invited cardiology clinicians, all of whom who have passed the board. So once you pass the cardiology boards, you will generally be invited to submit questions. And if that's something you're interested in doing, you may have a long-term relationship with the ABIM. So these questions are then submitted into a data bank, which is reviewed by a panel of clinicians who look at the question and they look at it and say, gosh, is this relevant to clinical practice? Is this a reasonable question, or is this something that is very esoteric? And in the past, they have excluded very esoteric questions, which would not be something that a cardiologist would reasonably be expected to know. They will also look at the question and say, gosh, is this testing an important point? Is it a reasonable question? Is it something that a practicing cardiologist should be familiar with? Now, once the clinicians are happy with the question, it then goes to a panel of professional PhD level psychologists who look at it and say, gosh, is there any way you can kind of work out the answer from the question? In other words, do the syntax imply a specific answer? Can you game it? Is the question written correctly? Is it written fairly? And they look pretty carefully at the syntax of the question to see, is this something that would be a suitable board question? Then the question itself is put on trial. It's added to an examination. They don't tell us where, but essentially it's added, and in that case it may not be marked. So they will test the new questions and see how they perform in relation to their standard questions. Is the new question correlating well with the past questions that they know have good discriminant value? So thinking about the question, what is the ideal board question? Well, the first thing is there must be a scientifically accurate answer. If nobody is fully sure what the answer is, or the answer is not in the scientific literature, and by the scientific literature I mean the peer-reviewed literature and specifically the society guidelines or specifically large randomized clinical trials, then how do we know what's right and what's wrong? So the board in general will stay away from areas that have not been clarified. If nobody knows the scientific answer to a question, then you can't possibly ask the candidate the question. So the board will concentrate on areas where there is a scientifically accurate answer that is derived from the peer-reviewed literature or specifically from society guidelines, which in turn are based on the peer-reviewed literature. So if there is a randomized trial which has come out within the past year, that's highly unlikely to get into the examination because it hasn't been around long enough, and it takes a while to go through the process of getting into being a board question. Equally, any of the learned society consensus documents or guideline statements that have come out within the past year are unlikely to be on this examination. But equally, any major trials in cardiology that have come out between 5 years ago and a year ago, or between 10 years ago and a year ago, they're fair game, as are any of the consensus documents that have come out more than a year ago. The board really loves guidelines and consensus documents, and these are eminently testable. So questions appearing for the first time in the boards are considered to be pre-tested. The pre-test questions are not identified, but these questions are graded along with the candidates, and then the board can determine which of these to include in the live or scored part of the examination and which it will recycle onto the next examination. What questions will not be on the boards? Well, the results of clinical trials less than a year, less than 2 years old, the results of the AHA-ACC guidelines less than 1 to 2 years old. Controversial issues, as I alluded to previously, cannot be tested. If there is no clear scientific answer, you can't ask a candidate what the answer is. K-type questions that you'll remember from medical school, that is, part 2 and 4 are correct, 1, 3, and 5 are correct. There are no K-type questions on this examination. The reason is you could game the questions if you knew part of the answer. There are no double negatives, but there are single negatives. A single negative is all the following are correct except. The way you approach a negative question is you approach it as if it's a positive question, and you will say, gosh, 2, 3, and 4 are correct, and I realize it's a negative question, so I have to invert it. Therefore, I will go back and mark 1, which is the incorrect part. But with a negative question, especially when it's late in the exam and you're getting tired, be very careful that you don't get tripped up with the syntax. The board will not ask you either double negative questions and will not ask you device-specific or technique-specific questions. This is a test of general cardiology and of principles and practice, not of specific devices or techniques. Society guidelines are a wonderful source of multiple choice questions. Now, the guidelines will not be asked directly, but they will incorporate scenarios that will require detailed knowledge of the guidelines in order to answer the question correctly. Now, in general, they will focus on Class 1 or Class 2A guidelines. They will generally not ask you Class 2B, as generally this is getting into a controversial area where there is weak data, but it's reasonable to consider it. So Class 1, Class 2A are fair game. Class 3, which is the negative guidelines, are also fair game. So when you look at the society guidelines, look at the Class 1, look at the Class 3, look at the Class 2A, forget about the Class 2B. If you want to give an examination question using a scenario that is based on the guidelines, there must be a scientifically clear answer, and the Class 2B is too weak in this situation. Clinical trials in cardiology are a very important source of new information. Most important clinical trials end up in society guidelines. Ideally, you should know the data behind the society recommendation, but if you're short for time, learn the guidelines first. The guidelines reflect the clinical trials, but it is better to understand what the clinical trials are based on, and hopefully you will want to read the original clinical trial to understand how the committee came to its recommendations. Now, remember that clinical guidelines have a checkered track history. Remember that we in cardiology had endocarditis guidelines which were available for 70 years, and for 70 years we gave people antibiotics in very complex regimens, and that was all completely wrong. So just because something is endorsed by a clinical guideline, historically some of these have been wrong. So it's important to understand the strength of the data behind it, and as you know, the societies give you the strength of the data when they talk about guidelines. So just because a society says that such and such is a recommendation, it may fly for the boards, but always maintain a healthy skepticism with regard to this. In this examination, you will be presented with a number of emergency situation questions. The board wants you to make a quick diagnosis to be effective and definitive in your treatment. You always err on the side of the most serious diagnosis. So for example, if you're given a rhythm which you say, gosh, this could be ventricular tachycardia, or maybe it's supraventricular tachycardia with aberrancy, if in doubt, assume it's ventricular tachycardia and treat accordingly. So the board classically will give you something like a cardiac tamponade. Now, the patient will be in shock, but they will not tell you this is cardiac tamponade will shock, but they will describe it. They will say, gosh, the patient is white and ashen and doesn't feel good. His blood pressure is 70/30. He's tachycardic and he's got a pulsus paradoxus. So you will need to say, gosh, based on the data, the patient is in shock. Remember with cardiac tamponade, if the patient is in shock, you will generally want to tap this under echo guidance, with the exception if it's related to trauma. You may want to take the patient directly to the cardiac surgery suite. With ventricular tachycardia, if the patient is hemodynamically unstable, it is always appropriate to shock the patient. Any hemodynamically unstable rhythm, shocking the patient is always appropriate. Okay? With an aortic dissection, they may want you to take the patient directly to the operating room without doing a number of investigations if the patient is clearly in shock and is deteriorating rapidly. So with an emergency situation, be decisive. Don't be afraid to make a bold decision if it's what you would do in clinical practice. Every unstable rhythm in a patient that's hemodynamically unstable, shocking the patient is always the correct answer, provided the patient is not DNR DNI. Unstable cardiac tamponade, tap under echo guidance except if there's trauma, emergency CV surgery. Unstable aortic dissection, emergency CV surgery if appropriate. Now, in non-emergency situations, the board wants you to be a little bit more reflective. And if you're given a scenario where they offer you a test that will give you more physiological data, in general, that is the correct way to go. So, for example, if they have a patient who has heart failure and who has a decreased ejection fraction, you're thinking about going to cardiac surgery, it may be reasonable to do a viability study. So if they offer you a PET scan, think about it. The other thing to think about is if they give you highly specific physical signs, these are almost always a strong indicator to the diagnosis. The physical signs will not be named by ABIM. They will talk about a systolic murmur that accentuates with forced breath holding. So they're talking about hypertrophic cardiomyopathy and the patient is doing a Valsalva. So if you see a very specific physical sign, I'm going to give you a few examples here. Fixed splitting of the second heart sound is atrial septal defect. In the context of congenital heart disease, if they say the patient has a single second heart sound, think about tetralogy of Fallot, although it can exist in some other congenital heart conditions. If the aortic second sound is absent, in a valvular heart disease patient, think of aortic stenosis. Absent pulmonary second sound, think about pulmonary valve stenosis. Be very sensitive to these very specific physical signs. If they tell you the patient has a systolic murmur, it doesn't help you a huge amount, but these very specific signs are very strong clues to the diagnosis. The board may tell you that a diastolic sound is heard, and you need to say, well, gosh, which of the following 4 sounds can it be? Is it a pericardial knock? In other words, think about the JVP, think about constrictive pericarditis. Is it a physiological S3 in somebody who's otherwise healthy? Or is it a heart failure patient or a patient with severe mitral regurgitation when it's a pathological S3? Could it be an S4? Could it be an opening snap in mitral stenosis? But the board will not tell you, and an opening snap was heard. They will tell you there was a sound early in diastole. Subungual hemorrhages or splinter hemorrhages, forced breath holding is the Valsalva maneuver. The physical signs don't lie in the board examination. So prominent Y descent in the JVP, think about constrictive pericarditis. Note that you can also see a prominent X descent in constrictive pericarditis. Prominent X descent in the JVP, think of tamponade. Remember that the Y descent is absent or almost absent in tamponade. So if they're giving you a patient and they're talking about the neck veins, think about their prominent Y descent as being very suggestive of constrictive pericarditis. Absent Y descent with a prominent X descent, think of tamponade. Absence of the X and Y descent, think about an RV infarction. Variable size A wave, they're talking about Canon A waves, think about AV dysynchrony, heart block, or ventricular tachycardia. So this is an example of a 58-year-old man with class 3 dyspnea. He's got a loud systolic murmur, and see here the board are telling you that the aortic second sound is absent. In other words, they are screaming at you that this is aortic stenosis. The echocardiogram shows equivocal findings, aortic valve area of 1.1, mean gradient of 25, but note that the ejection fraction is poor with an ejection fraction of 17%. So they give you suggestions. Well, there's an option for a surgical aortic valve replacement. There's an option for a TAVR procedure, or well, you could medically manage the patient. But what sticks out here is they've given you one option which will give you more physiological data. That's a dobutamine echo. In this situation where they're giving you the option for more physiological data and it's a non-emergency situation, invariably that is the correct answer. If the patient is asymptomatic and they give you the EKG, look for specific things. Look for repolarization changes. Is the patient African American? Look for left ventricular hypertrophy. That would suggest either severe hypertension or hypertrophic cardiomyopathy. Think about WPW syndrome or long QT syndrome. Think about Brugada. Brugada always comes up in this examination. Think about left bundle branch block or right bundle branch block or maybe atrial fibrillation. So have a list of conditions in the asymptomatic patient that you will specifically look for. How are the marks divided in this? Well, the board don't tell us. They suggest that the marks are given for equal time. Remember, they can delete certain questions. First-time questions may not be marked. Nobody is sure whether the ethical questions are marked or not, because obviously that's a very difficult area to test. Questions that perform poorly, in other words, they seem to correlate poorly with other questions, may not be marked. So don't worry about the marking scheme. Your job is to do the exam. It's impossible to divine exactly what the marks are, and to a large extent, it doesn't matter. So with the EKG portion of the board, you've got to be very careful. There is negative marking on the EKG and the imaging portion. Do not guess or do not overcode. The CV imaging section can be challenging. There will be some still images, and remember, we're not used to looking at still images either for ventriculograms or coronary angiograms or echoes, so get used to looking at still images. Sometimes they will give you a still image in systole and in diastole, and you've got to determine that the patient has a poor ejection fraction. So get used to looking at still images, even though that's not what we actually do. In the pure multiple choice section, Distinct from the imaging section and the EKG, there is no penalty for guessing. So the MCQ is one examination component that you must pass independently. The EKG and cardiac imaging is now combined into a second examination component that you must pass separately. So you must pass both standards. There is no grading on the curve. Remember that you will be compared with the candidates who went last year and previous to that. So there is no grading on the curve. There is an absolute passing standard which the board does not disclose but is internal to them. So tips for the MCQs: answer all the MCQs, guess and guess strategically if needed. Unanswered questions are automatically marked wrong. Do not leave any unanswered questions on the table. More than one answer may be partially correct. So when you see an answer that's correct, don't jump into it immediately, because sometimes one answer may be slightly more correct than another. So if there are two answers that could be correct, you need a judgment call to pick the one that is more correct, and your goal is to pick the most correct answer. The format of the board is similar to formats you've previously done for internal medicine. It is a computer-based examination. ABIM contracts with Pearson VUE computers. You go to the examination center. Make sure and look at the video from Pearson VUE just to familiarize yourself with some of the details. I will not talk about recertification, as one of my colleagues will address that, but essentially it's the same multiple choice questions with the exception of the EKG and the imaging section, but it may be marked a little bit differently. The details are not disclosed to us. So when you go to the Pearson Center, there's a clock in the room, there's a countdown timer on the computer, there's a 5-minute warning. You lose time if you leave during the examination. Do not leave during the examination for any reason. Time is a limiting factor in this examination. The board will tell you you have adequate time. My experience is you have just enough time to do it, so do not waste time. Format of the boards: it's a 1.5-day exam. 1 day, 4 2-hour sessions to complete 60 MCQs per session. A half day then for the EKGs, cardiovascular imaging, and this is only for first-time takers. And this includes echocardiograms, ventriculograms, aortograms, and coronary angiograms. Test center are paranoid with regard to identity. You think the TSA are paranoid. The test center people will confirm your identity. They will take photographs. They will take your fingerprints. Remember that you cannot take any watches, pencils, or calipers into the exam. There are electronic calipers on the computer. Get used to doing it. You can play with it with the downloaded video that you can watch before the exam. It's a little bit unusual, but please practice with it beforehand. Ask for earplugs. Ask for a notebook. Remember that the person in the cubicle beside you may be doing their fireman exam or ambulance exam, but ask for a notebook so that you can sketch out questions or play with formula. Ask for earplugs. Use the electronic caliper beforehand. If you're left-handed, ask for a left-handed mouse. Adjust the computer screen. The blueprint for the examination is given by the board. As you can see, there's a lot of valve questions, which is 12%. Arrhythmias, 12%. Myocardial infarction, 12%. But what's really interesting is there's a lot of other areas that you can pick up or lose marks. So vascular disease is important at 9%. Pharmacology is 5%. Heart failure, as you'd expect, is a very large section. Congenital heart disease is 7%. Hypertension and pulmonary hypertension is 7%. Pericardial disease, 3%. The miscellaneous questions obviously can be: how would you interpret a p-value or some very elementary statistics? Remember that there's usually 1 or 2 ethics questions on the question. The question type are single best answer, or true or false. There is no negative marking in the MCQ, always guess. They can ask you to interpret specific studies, including electrocardiograms. You can be asked intracardiac electrograms. Usually these are pretty basic. In other words, there's usually a block in the bundle of His. There will be a VT versus an SVT. There will be a WPW syndrome. They can give you hemodynamic data. You are expected to know basic hemodynamic formula. It's fair game to give you an MRI, a CT, a nuclear or PET image. Remember, if you get a PET image, they're looking for viability, so there are a very limited number of choices. The long question is usually a problem. So they will give you a very long question. You are tired and you say, gosh, is this something I really want to wade through? The trick is to look at the answer options, look at the final paragraph, and then say, gosh, do I really need to go through all of the question? So the long questions, they tell us, is to test whether candidates can assess relevant information. In other words, pick the needle from the haystack. Read the last paragraph of the stem, read the answer options, read all the questions if necessary. Cardiac motion studies, they will show you ventriculograms, aortograms. These can be either static or dynamic. Get used to them, look at them in both formats. They will show you echocardiograms in this exam. EKG is very important, and we have a specific lectures on this. There's usually 1 to 3 main diagnoses per EKG. There are subsidiary diagnoses, but these are usually of very, very little value with regard to marks. Remember, you need to hit the nail on the head. When you look at the EKG, look for the 1, 2, or 3 main diagnoses. Do not agonize about small amounts of left atrial enlargement. That is not going to be the main issue. Be conservative, be on the side of patient safety. If you're not sure whether it's VT or SVT, always pick VT. Watch for the second diagnosis. If the patient has an inferior wall myocardial infarct, always look for heart block. Beware of metabolic EKGs. Look for hypokalemia, look for hyperkalemia. Watch for the tip-off in the clinical scenario. Are the patients on dialysis? Are they vomiting? Are they on cardiac medication, meaning digoxin? Is it a routine EKG? Is it somebody who's asymptomatic? Is somebody an African American where there may be hyperpolarization changes? Watch for patients with thyroid surgery when you'll be looking for changes in calcium. If you look at the EKG and you're not seeing a whole lot on it, look for posterior and lateral wall infarcts. Look for WBW syndrome. Look for Brugada syndrome. Look for prolonged QT. Epstein's anomaly comes up on this examination frequently. The stated incidence of Epstein's anomaly is 1 in 500,000 people, but for board purposes, it's always there. Remember the diagnosis of ASD, both primum and secundum ASD. There are many diseases which appear to be very common in the boards, not so common in clinical practice. Hypertrophic cardiomyopathy, amyloid heart disease, aortic dissection, penetrating aortic answer are frequently asked. Constrictive pericarditis and differentiation of constrictive pericarditis from restrictive cardiomyopathy based on the echocardiogram is very, very common. Remember interdependence of the ventricles in constrictive pericarditis. Atrial myxoma comes, myocarditis. Remember the myocarditis trial showed that immunosuppressive therapy or steroids was not helpful in lymphocytic myocarditis. Epstein's anomaly seems to come. Physical signs are incredibly important. Know the effect of specific maneuvers on murmurs. By specific maneuvers, I'm talking about Valsalva, hand grip, leg raising, squatting, and the way to do this is to think about the physiology that's involved. You are expected to know the physical signs of valve disease, both of the diagnosis of the lesion and of the severity of the lesion. Be aware that there are significant differences in the physical signs between acute and chronic mitral regurgitation, acute and chronic aortic regurgitation. Likely board questions include unusual presentations of common cardiovascular disease, in other words, myocardial infarction during pregnancy, rare cardiovascular diseases, Takotsubo syndrome, amyloid heart disease. The board likes complications of therapy, how you would pick this up, how you would manage it. In other words, if a patient has a septal ablation for hypertrophic cardiomyopathy, what are the possible complications of this? If a patient has atrial fibrillation ablation, be aware of pulmonary vein stenosis. The board likes clinical trial data, and the board truly loves society guidelines, which were made for multiple choice questions. Be able to interpret CV imaging that will lead you to a specific treatment. Think about unusual things such as myocardial infarction in pregnancy. Think about cocaine, spontaneous coronary dissection, which has been asked in the past. Think of thrombophilia or phospholipid syndrome, which increase the risk of myocardial infarction very dramatically. Think about issues that we don't think about every day, such as cerebral hemorrhage with thrombolytics. Think about the predictors, in other words, older age, female sex, black race, prior stroke, systolic hypertension, excessive anticoagulation, and low body weight. Peripheral vascular disease is an important part of this exam. Remember, we're cardiovascular specialists. So there will generally be 3 to 6 questions on peripheral vascular disease, often either Berger's disease, interpretation of non-invasive vascular imaging, or treatment for peripheral vascular disease. There will typically be an aneurysm, either an ascending aortic aneurysm or descending aortic aneurysm in this. How would you manage it? What are the indications for intervention? There is usually a question on stroke, and particularly with the recent trials with emergency thrombolysis for stroke, I would suggest that this may be a possible question. Think about the unusual vasculitides, Berger's disease, Takayasu's giant cell arteritis, Kawasaki's disease. Think about antiphospholipid antibody syndrome, and there's usually one question on this. Think about management of retroperitoneal bleed. Aortic disease includes aortic dissection, penetrating ulcers, aortic vasculitis are commonly asked. Congenital heart disease is important. Remember, you are not expected to be a congenital heart disease expert. Remember, there is a separate board examination for people who have a special interest in congenital heart disease. But you will be asked the basics of congenital heart disease. So in general, there is usually 4 to 8 questions on patent foramen ovale, ventricular septal defects, Eisenmenger's tetralogy. They may also ask you questions on the more unusual congenital heart disease such as Epstein's. There's often a question on pulmonary valve stenosis or on bicuspid aortic valve, which is very common. Less common congenital lesions such as transposition of the great vessels have been asked. They will ask you the association with specific syndromes. They will ask you with regard to arrhythmias and sudden death in congenital heart disease. Patent foramen ovales are something that the board often asks. Remember the scuba diver question, or the platysma aortodeoxia syndrome, that is dyspnea and arterial saturation in the upright position with improvement in the supine position, has been asked previously on this examination. Patent foramen ovale questions talk about secondary prevention of stroke. When would you place a device? How do you differentiate patent foramen ovale from an atrial septal defect? When would you go to surgery then place an occluder device? Valve disease is very important, and I suspect that there will be a significant number of questions on TAVR procedure this year. They will ask you the indications and contraindications, indications for proceeding with aortic valve replacement in patients with minimal symptoms. How do you investigate patients with aortic stenosis? How do you make a decision whether patients with aortic stenosis go to surgery? Endocarditis is usually good for 1 to 2 questions. Remember, endocarditis prophylaxis is almost gone, with the exception of patients who have previous endocarditis or have congenital heart disease or possibly have prosthetic heart valves. No aortic stenosis, especially low gradient, low ejection fraction, low flow. Be aware of the dobutamine stress test. Prosthetic valves, both choices of prosthetic valve dysfunction are usually fair game for 1 to 2 questions in the boards. Pericardial disease is a common question. They will ask you about acute pericarditis. Be aware of the patient with acute pericarditis that they will try and get you to give a thrombolytic to. So if you see lots and lots of ST segment elevation, look carefully for PR depression, which is pathognomonic of acute pericarditis. This is due to inflammation over the atrium that you do not get in myocardial infarction. Remember, you do not want to give a thrombolytic in this situation. Pericardial constriction is fair game. They will usually show you this in conjunction with an echo or a CT scan or an MRI. Congenital absence of the pericardium and association with sudden cardiac death has previously been asked. Pericardial effusion, tamponade, specifically the physical signs of tamponade, are an important question. Acute pericarditis shows diffuse ST segment elevation in multiple leads, multiple territories beyond a single coronary, PR depression. Remember, this is often a trick question. Remember, there are variations in pericardial disease such as effusive constrictive pericarditis or bleeding after cardiac surgery where there is a hematoma compressing the right ventricle. Pericardial tamponade, tachycardia, hypotension, paradoxis, and with the typical JVP findings that we've previously talked about. Remember, regional pericardial tamponade can be difficult to diagnose, but is fair game. Low pressure cardiac tamponade has previously been asked. Remember, if you get a lateral chest x-ray, they're looking for either pericardial calcification, position of the pacemaker lead, or right ventricular size. Cardiomyopathy is on the boards. Cardiac physiology can be asked, but this is usually clinically relevant. Important areas for cardiac physiology are renin-angiotensin system, the endothelial function, platelet function, and receptors. Hypertension, both systemic hypertension and pulmonary hypertension, pulmonary embolism are fair game for the boards. Generally, they will usually be 5 to 9 questions on primary and secondary causes of systemic hypertension. They will ask you pulmonary hypertension, especially management of patients with pulmonary hypertension and differentiation of causes of pulmonary hypertension. They will ask you hypertension and malignancy, and there's usually 1 or 2 questions on sleep apnea syndrome. Think about treatment of massive pulmonary embolism and the indications for thrombolysis, which I've included on this slide. The indications for thrombolysis are persistent hypotension, large perfusion defect, right ventricular dysfunction, severe hypoxia, presence of patent foramen ovale, or free-floating thrombus within the right ventricle. There are a couple of miscellaneous questions. They usually talk about p-values, confidence intervals, predictive values of tests, no Bayes theorem. Think about interpretation of randomized clinical trials. Finally, we're back to William Osler again. Perfect happiness for the student and teacher will come with the abolition of examinations, which are stumbling blocks and rocks of offense in the pathway of the true student. Maybe the ABIM will actually take note of Osler, but in the short term, I don't think there's going to be any changes. Best of luck on your examination, and thank you for coming.